I wanna slow dance if you feeling me now.
Hello everyone, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at BrightMD. Just a few housekeeping items to go over. We would like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion. Stay on after the webinar to create some seriously spooky cocktails and mocktails with mixologist Tracy. And with that, I'll throw it over to our moderator who joins us from Chillmark Research, Alex Lennox Miller.
Thank you so much, and thank you to everybody listening in. This is the Could Coronavirus Save Primary Care panel. I am joined by three really fantastic speakers. I'm very excited to go over the topic. Before I introduce them, I do want to say that the Q&A function is available. We will be answering questions at the end of the panel, but we'll also try to address them, anything topical or interesting that comes up during. So please do not wait to submit your questions to the panelists. Joining me today is Karen Murphy. Dr. Karen Murphy is Executive Vice President, Chief Innovation Officer, and Founding Director of the Steele Institute for Health Innovation at Geisinger. Dr. Murphy has worked to improve and transform healthcare delivery throughout her career in both the public and private sectors. Before joining Geisinger, she was Pennsylvania's Secretary of Health, addressing the most significant health issues facing the state, including the opioid epidemic. I'm also joined by Erin Bali. Erin is co-founder and CEO of Carbon Health, as well as chairman and founder of Udemy, the largest marketplace for online courses worldwide. He has been included in several prestigious lists, including the Forbes 30 Under 30 and Business Insider's Top 100 Innovators. Before that, Erin graduated from METU in Turkey with a degree in computer science and mathematics, winning several awards in mathematics, physics, computer science, and chess, including the International Mathematical Olympiads. And finally, we're joined by Dr. Ray Constantini, CEO and co-founder of BrightMD, the leading care automation company in the virtual care space. Dr. Constantini is a pioneering healthcare executive, an innovative physician, and a seasoned entrepreneur who is passionate about making healthcare better. Prior to founding BrightMD, he led the design, build, deployment, and operations of three groundbreaking telehealth and digital health products at Providence Health and Services, one of the largest health systems in the country. I don't think it's going to be a shock to anybody on the panel, and I don't think it'll be a surprise to anybody listening that the primary care system has been struggling for a very long time. And I don't think it's a controversial statement to say that most of the difficulties or obstacles that it's facing now in COVID aren't so much new problems as exaggerated and larger versions of problems that already existed. When we look, for example, at the latest survey from the Primary Care Collaborative, it tells us that there aren't enough providers, not enough physicians. They don't have enough time to see their patients. There are empty positions. They're concerned about the volume of patients that they have, especially with flu season approaching. They feel exhausted. They feel depressed. They are suffering from extreme anxiety, both for themselves, their staff, and their patients. None of this is new. These are just worse problems than we've seen before. But it's possible, and it seems like one of the odd sort of silver linings of the coronavirus epidemic has been that it maybe will allow us to break through the inertia of the previous status quo. Let us find new ways to care for patients, to leverage technology, and to deploy healthcare in innovative ways. The first question I have for the panel, we saw, I think, and continue to see that most of the emphasis has been on telehealth. From your experiences in your organizations and with your providers, do you see telehealth as really the key to care going forward? Is this going to be one of those key transformative elements, or does the focus on telehealth sort of miss the forest for the trees? Karen, we'll start with you.
Thank you, Alex, and thanks for having me today. No, I think I think virtual visits are truly a way to transform healthcare delivery. I think in the pandemic, we were somewhat reactionary, and that's a good thing. So we were able to reach our patients virtually and saw the value of that, of what is the value of reaching our patients where they are. But I think it sets the stage now for us going forward after the pandemic, to really say, how does virtual health integrate into all care models to create value? So it's not just creating the visit that we would have done before in person, it's what visits and what touch that we give our patients really translates into better outcomes, and while always lowering cost.
Aaron, we'll ask you next.
I think what we are, when the pandemic first started, we started seeing a kind of pike of the increase in the virtual care visits, and then it started scaling back a little bit. But what it is here to say is what we call omni-channel care. So because what accelerated the industry is the adoption of almost every provider to the virtual care tool. So at this point, I think patients will start expecting every provider to be available virtually as well as in physical locations. I think this is true for primary care, urgent care specialists. So, and with virtual care, there's usually an inertia for the first visit. So people are skeptical until they solve a problem virtually for the first time. But once that's over, actually most patients tend to come back for virtual visits. But as I said, I think instead of a fragmented world where there are telemedicine providers and clinic providers, we would expect almost all the providers to be omni-channel. And lastly, one of the things, for example, that worked really well at Carbon Health is we merged the virtual and physical even further. So we started putting up pop-up clinic locations where the doctor is available over the video, but the nursing staff is available in person. So this way you can actually take care to previous healthcare deserts while still kind of maintaining some kind of operating margins, because again, there are certain locations that are getting full-time doctors employed there couldn't be utilized well enough, but we did the model where we are mixing virtual doctors and in-person clinical staff. So I think that actually very creative models coming out of the market.
Ray? Ray, you're muted, unfortunately.
I'm telling you, when we all get done with this, I'm going to walk into in-person meetings and I'm going to have to check if I'm muted. Apologies. No, I think there's some really great points there. I would start first with a bit of an analogy for where we're at. And I think this really plays off of where you started the conversation, Alex. I mean, the foundational problems that have plagued primary care and healthcare as a whole, you know, whether that's patient access or provider burnout, the rising costs of care, are challenges in shifting from fee-for-service into value-based care. Those are arguably the big, hungry, angry bear that's been looming and threatening healthcare for a growing 2 decades. That hasn't gone away. What we have is between us, healthcare, and the bear is this fire of COVID that's come up, and it has consumed our attention and drawn our focus, understandably and appropriately, because it's a fire and it's in our face. I would also say that fire has also singed the bear and made it more angry, and it's more hungry, and it hasn't changed any of it other than exacerbating those problems that were already there. And coming back to the question that you'd asked, I think Karen and Aaron had both talked about some of these pieces. I think telehealth is great. I think it changes geography. It changes where healthcare can get delivered, and it makes care more convenient. And I think that that's wonderful. And we should be doing that whenever possible, because care should be convenient. When we can make it convenient, it should be. But I also think that changing the geography of healthcare doesn't address any of the problems that are the bear. It helps with the fire right now. I mean, the reason that telehealth exploded is because we didn't have a choice. We needed to resolve geography as a barrier to care. That will fade. That need, that criticality will fade. And what we really need to be thinking about is not just how do we change where healthcare can get delivered. We need to be thinking about how we can deliver care. How can we change not just the context of healthcare, but change the construct of it? And to me, that's the really exciting opportunity that comes from this. And Karen had mentioned this around virtual visits, and Aaron had talked about this in terms of omni-channel. It shouldn't be telehealth versus in-person care. I think that's a false dichotomy, and it forces us into a mindset where they are against each other, when really what we should be thinking about is how do we blend those modalities? How do we use digital tools to change the way that we're delivering care? How do we make it more seamless? How do we help patients find their way to the right location? And that may even be dynamic throughout a single patient encounter based on what is going on with them. You may start in an asynchronous setting, and then we discover that you actually need some in-person evaluation. How do we make that handoff seamless? How do we make it so that we've gathered the right information from all of the possible sources? We've transformed that data into information, and we put it in the hands of clinicians in a way that's powerful, impactful, actionable, and valuable. And to me, that is the digital transformation that healthcare has to embrace, and that I hope that if we're going to get a silver lining out of this COVID fire that's in all of our faces, I hope that the acceleration that we've seen among patient expectations, provider acceptance, and a sense of healthcare necessity is going to move that forward.
You know, it's an interesting point, because the question of what do we need to do immediately versus what do we have potentially capacity to do, or the tools to execute with, are sort of two separate questions. And Karen, you discussed this, and Ray just mentioned it. I'm curious, as especially for Aaron and Karen, as you guys progressed past the earliest stages of the pandemic, when you were forced to implement telehealth or forced to make these transitions as quickly as possible, how did you identify what the most important next steps were in terms of implementing digital or virtual tools, and how did you integrate them most successfully into your care pathways?
So I could start, Alex, and that's a great question. And it really was evolutionary as we went through the pandemic. So, you know, we say back on March 13th, our tools consisted of graph paper, graphing out the positive tests that we had in the area. And now we have this sophisticated panel of data analytics that supports our decision making. And I would say the care models were very much similar to that in terms of truly the evolution. I mean, the first was, we're going to take down all of our elective work, our surgery, our clinic visits. And it was really, how do you do that? And the thoughts, you know, it really, 6-8 months ago, if somebody said cancel a week of activity, you would have said, we can't do that. I mean, there's no way we could do that. And yet that's exactly what we did. So we took the system down and really looked at the tools that we had available to us, which was virtual health, telehealth visits, and who needs us the most? That was the question that we asked. And really, I think going through the transformation that's possible post-COVID, that's what we should be asking, is who needs us the most and how do they need us? And then we fired up the virtual visits along with remote monitoring, because really we needed to do both for our patients, particularly those patients that were going to suffer really inferior outcomes because they weren't seeing a physician or an extender on time. So that evolution really took place over the 6 months. How do we get what first of all, answer the question, who needs us the most? What do they need? What interventions are going to be remarkable? We noted that our admissions for congestive heart failure and COPD were dramatically decreased during the first phase of COVID. And what we came up with to say is there had to be something more than just fear of patients not wanting to go to the ED or to be treated. So we're actually now looking retrospectively is what did we do for those patients that allowed them to stay out of the hospital? So I guess my answer to you would be evolutionary. That's what we learned in the care model going through the pandemic. And I think some of those questions are going to be very salient as we look at transformation post-COVID to say who needs us, what do they need, and how do we meet those needs, whether that be, and the last place we want to meet those needs is in a bed in the hospital. We want to meet those needs either in the primary care setting or even more favorably in the patient's home.
We got our first question, and it's very, very salient and directly to you. Who did you decide needed you the most?
Patients with chronic diseases. So those that would suffer, particularly if you think about it, COPD, diabetes, and congestive heart failure. Those patients that could really face an exacerbation of their disease require higher, our goal at that time was obviously keep everyone out of the hospital, really for the safety of the patients. It wasn't, at that time we didn't know a lot. And we knew that it would be better if we take care of them in the home. And I think we, if you look at they were the patients that needed us the most, and they were the patients that we focused on the most to make sure that we were touching them on a regular basis.
Right. Aaron, you kind of addressed this a little bit in your answer to the prior question, but as you guys moved past your immediate tasks or the quickest things you thought you could do, how did you prioritize next steps, and what did you end up choosing?
Yeah, so actually I need to highlight something about carbon health. So we are a technology company at the core, so we own the entire tech stack between the patient and the provider. We actually spent more like 2.5 years building the technology before we started seeing patients on scale. So we had that advantage, and we had been doing both video visits and in-person visits since we started. So for us, there wasn't any barrier to switch to virtual because we were already doing this. But I want to highlight some other things that we built during the pandemic. So just quick timeline: January 25th, the first person from Wuhan, China, came to our clinics with COVID-like symptoms. So we've been actually in this since the really early days, but there was no testing available back in the day. So we have pre-appointment triage system where we collect a lot of those answers for any visits ahead of time. So we quickly adjusted that to kind of screen for people traveling. So that's how we call this 2 patients coming to our clinics. Because there was no testing in the beginning, we quickly built a remote patient monitoring system for patients who had COVID-like symptoms, but where we couldn't actually get them tested. Actually, in fact, one of those patients ended up becoming the first California patient, which was marked up as the community spread patient because there was no travel history, but everything else can match the profile. So when the pandemic first hit us hard in the early March, the volumes were really high. We made virtual care free for everybody just to be able to handle the load because the clinics were completely booked. We started building a lot of systems to actually triage high-risk patients, separate them from others. So it was actually, I would say in the last 6 months, we have been pushing weekly product launches to our platform to be able to add up changes. Because over time, for example, you realize that we collect a lot of very structured data that is not typically accessible in traditional healthcare providers. We were the first company in the world who published large-scale open clinical data set. So we essentially every COVID testing patient, we put all of their labs, vitals, symptoms, all the detailed clinical data set. But we put enough noise in the data so the individual records cannot be identified. But the researchers were able to use our data to kind of build risk scoring profiles. So there were all those innovations like this on the way. And lastly, and most recently, we launched a program for actual COVID positive patients. So there are now 7 million identified COVID patients. We launched the first rehabilitation program to get them back to their full health. So we hired a well-known pulmonologist from Cedars-Sinai to run the program. So for us, like this has been pretty much a weekly exercise of what's the next technology we can build. I mean, and one more example is like we built the largest map for all testing locations in the country. So both like Google and Apple actually are using our data set in their maps product. So it is for us like we also did a lot of things on the services side. So we tested 300,000 people, built at-home testing kits, we built mobile testing units. So we both did a lot on the services side, but also the technology side in the same time.
Great. Ray, I know the question is a little bit different for you given the different organization type, but I'm curious to hear your thoughts on this.
Yeah, I mean, I think there's a couple of different things that we've seen. So one of them is that we've seen health systems increasingly embrace the need for velocity. I've heard from many health systems, IDNs, that they'd never felt the need for the kind of velocity of change that they've been experiencing and embracing. And they didn't know that they had the ability to be able to move at that kind of a pace. And I've heard a lot of folks bring that up and talk about that and actually seek to sustain that. Another one I think is really what we've seen is bringing tools that really bring value to everybody involved. Healthcare is complicated. In any given healthcare transaction, a visit, there's really 3 different parties that are involved, at least, arguably 4. I mean, you got the patient, you've got the clinician, you've got the health system, whose interests may or may not be fully aligned with that clinician or the patient, and you've got the payer. And that's the vast majority of transactions that are happening. And it's really difficult to be able to bring tools that bring that kind of comprehensive value to all of those involved parties. And you know, we've found that particularly in times of urgency and increased need, those kinds of tools can be particularly valuable. We have always sought to be able to do that as a company, BrightMD, I think shifting us from these tools where arguably our clinicians are working for the computer rather than the other way around is something that we've seen a lot of value around. As a clinician myself, I know I'd spent way too much time working in EMR systems that were arguably designed to optimize billing, not to optimize clinical outcomes or clinician workflow or patient or provider experience. And arguably, you know, coming back to the earlier question and tying this in, you know, video-based telehealth certainly can solve problems, but it arguably, again, changes the context. It doesn't do anything that substantially positively impacts the clinician. It makes care more convenient for the patient, but everything that needed to happen in an in-person setting still needs to happen in that video-based setting. I saw this when I was implementing telehealth services a decade ago. It actually often took longer to deliver care in a video-based setting than it did in an in-person setting and at a fraction of the reimbursement. And even if you're doing parity, if you're consuming more of your most rate-limiting, capacity-constraining resource of clinician time and getting parity reimbursement for that, that's a net loss for the health system and for healthcare as an industry. So truly bringing tools that can change and support and augment that clinician workflow, make the patient experience truly better, make care more accessible. I mean, you know, because we started out with telehealth and that's part of what we do, I'll mention you can't do a video encounter from your cube at work. You're not going to sit at your cube and talk about your UTI or your foot fungus. I mean, that's just not a viable option. So, you know, we often hear questions about how do we better manage this digital divide that has further separated our two-tier health system. Those who can access care digitally because they have Wi-Fi and a high bandwidth connection and the digital savvy to be able to do that, and those who don't. Bringing tools that simplify that for the patients, things that can, help patients who have English as a second language, that diminish that barrier that comes from clinicians who inevitably slip into medical ease. It's hard for a clinician and a patient with a 4th grade reading level to have effective conversations. There are tools that can help with that. And those are the kinds of tools that we see being particularly valuable, a heightened sense of value right now, even more than they were pre-COVID. So.
This gets very well into a question that from the audience that I really wanted to get to. Obviously, we're talking about now a slightly more technologically involved patient. We're talking about a patient who needs more resources at hand or at home. As we're discussing this potential evolution, how do we adapt the model so that people who don't have access to those resources or to that infrastructure can still access and afford care?
So I think in the how we should look at this is really the appropriate allocation of resources. So we have a finite number of resources within a primary care practice. I think we have to, the hope we have going forward is really to be able to answer the question of what does virtual do for us? But then if we allocate our resources better than we are today, presumably there will always be that group of patients that are digitally challenged in terms of whether it be broadband, whether it be not have a phone. And presumably we will be able to, Nirvana would be able to reallocate our resources to be able to have human intervention for those patients that don't have the digital capabilities. And I think that's the promise of digital for primary care, is that we should be able to utilize what we have in a more efficient way. And perhaps we should stop thinking about replacing in-person visits and instead thinking about revamping what primary care looks like and looking at all the tools that we have available to us and our population that we're serving and match those up accordingly.
Yeah, I see two pieces to this one. So particularly I would agree with you, Karen. Part of it is matching our resources with patient needs. I think that's a complicated thing. I go even a level deeper on that. But first, I think there's two aspects. One is bringing better tools that are accessible to patients. One of my favorite analogies, I don't know how many people out there spend a lot of time in the kitchen, but there's this great kitchen tools company called OXO, O-X-O. And the history that they have is really interesting. They were actually a company that was first developed to create kitchen tools for patients with rheumatoid arthritis. And for those who don't know what patients' hands look like when they have advanced rheumatoid arthritis, this is a crippling condition that you wouldn't, it's difficult to use a spoon, much less a peeler. But by designing tools that worked for their hardest audience, they created something that was accessible for them and delightful for everybody else. And I think healthcare hasn't done a good job of really designing that way. And I think that's been one of the principles that we've embraced from very early on, is how do we build tools that the least tech savvy folks can use. If you're struggling with language barriers and you have a 3G connection in a rural setting and a cell phone and no computer, and a paper-made data plan, how can we build tools that those folks can use? And that makes the experience for others accessible and delightful and better. The other piece, I think, comes back to your point, Karen. I mean, as a clinician, the interesting thing is if you think about what we sell as clinicians for a moment, I know this is a weird hat to put on, even for me when I do both business and clinical, but wearing the doctor business hat for a moment, we sell 20-minute increments of our time in primary care. That's the product that we sell. And if you come in with a cold, we sell you about 20 minutes of our time. And if you come in with diabetes, congestive heart failure, COPD, a foot ulcer, and a whole bunch of social determinants issues, we sell you about 20 minutes of our time. And that's not the way that clinicians want it. It's not the way that patients want it. It is a broken way to deliver care. And so bringing tools that free up clinicians, that let them spend 2 to 3 minutes on the cold, that is a true reallocation of resources. When clinicians are spending 70+% of their time on data collection and documentation, when it takes 100 clicks on average to complete a single visit inside of an EMR system, and we're doing that in an environment of scarcity, when there is more patient demand than there is provider capacity out there, that is one of the most wasteful and sad things that I can think about in an industry that I love. And so, I think it is about helping free up those resources so that they can be reallocated. To your point, Karen, let's take care of those quick visits in a quick way so that then we can bring the humanity back to the interactions that really need it. And I think that that's something that we've lost in a lot of ways with healthcare. And I know I've seen that digital tools can really help with that.
I want to actually a little bit more here if you have time. So
yeah,
I think Ray kind of brought up some really great points. But when we look at the population, I think there's two different things we have to achieve as healthcare providers at the same time. One is provide really efficient care when we can. And the reality is care becomes the most efficient when the patient has access to all the tooling, all the smartphone, the broadbands, the credit card for payments, all these type of things are really critical. But then we still have to be able to make it work for everybody else as well, right? So at Carbon, one of the things we did from since the day we started is we put ourselves as a hard requirement. We said with roughly Medicare reimbursement rates, we'll have clinics which are profitable with real high quality patient experience. So that was a hard requirement for us. So that was really that pushed us was to just take every single thing we can automate, remove, or make it more efficient. And then allow pretty much all that efficiency relied on the technology. So the example Ray gave, for example, was one of the first optimization opportunities we found was if somebody has a 20-year-old man with cold symptoms, that's less than a 10-minute visit. So just even being able to adapt to appointment durations so that the patients with multiple chronic conditions can get the 50-minute visit. The other ones can get the 10-minute visit. That's actually, there's a way to make it so that your patients are not waiting for you, you're not behind your schedule, but also you're really optimizing the clinician's time, because by far the biggest resource is the clinician time. So I think we did a lot of these things. And one thing that helped with the pandemic is, so we ideally expect all the patients to do their entire onboarding ahead of the time in the application. And that used to be done by 40–50% of the patients. With pandemic, people don't want to touch anything. So that number went up to 70–80%. So that actually really streamlined our processes. The fact that people did not want to touch any physical surface when they come to clinic really streamlined our process because everything became digital first. But then I think the other 20% is still critical. So, just back to our pop-up location. So the broadband access is a big limitation. So the pop-up, essentially what pop-ups are doing is taking virtual care to a demographic which doesn't have access to even internet access, right? And the language is the other barrier we are seeing. So essentially imagine you're in a rural setting, you enter a vessel and there's a local person who speaks your language, who can communicate with you. But we have broadband internet in that setup box, right? So that we can bring the clinician through internet. I think that actually, that type of a model probably is going to be needed to bring obviously the last 30%. We'll need some sort of physical access point because their home won't really have that access. So because between internet, language barrier, credit access barrier, those 3–4 things become too much to overcome.
Some of the issues that you're discussing, such as the amount of time that needs to be spent in documentation, the amount of time that's spent in a given appointment, is driven as much by the billing and regulatory requirements as it is by anything else. I I hate to, move the conversation over to, money, but to what extent should we be looking at the outcomes of COVID that have driven primary care closures, that have really plummeted primary care revenue, and look at them as a sort of real warning sign that this business model for primary care may just not be sustainable? Do we need to be looking at new models and new ways of compensating and paying for primary care?
Alex, you just waded in and grabbed a hold of the third rail of healthcare. Good for you.
Who wants to take that one first?
I can start just to keep the conversation. So probably the saddest thing about the pandemic was the economics of how it affected different entities, because these once in a time crisis points are what insurance companies are supposed to be here for. So you get insured against this like rare risk of having a global pandemic. Really, that's what our insurance premium should be going for, just like protection. And they have very strong balance sheets to be able to cover themselves. But the reality is they were the only real winners in terms of the financial impact of it. So with care, a lot of elective surgeries going down, insurance companies are now in a very good financial situation. And the healthcare providers, which typically have kind of lower margins and they have to be more operationally active to be able to survive, especially smaller practices. I mean, large health systems have enough cushion there, but smaller practices, which really rely on the daily cash flow, essentially they were the biggest losers financially, and the insurance companies, which were supposed to be protecting us against these unexpected crisis moments, have been very profitable. I think this shows that this is a very tight balance. A lot of small practices will fail, and they're still more roughly half of all the outpatient care in the country. So I think we'll need to switch to a value-based model where every patient, a sort of a patient panel belongs to a particular provider. If they don't get care as much, that provider still can compensate that. But so essentially the margins for lack of care or reduced rates of care should not be going to insurance companies. It should be going to the actual providers who are able to, for example, solve their problem virtually instead of in person. So I think the value-based care model, obviously, pretty much everybody aligns it's the right model, but we need to accelerate this faster. One tiny kind of thing I think that happened positively just going to highlight the positives. There are some rules regulating what a clinician oversight, like physician oversight, would mean. So previously it used to require the physician and the overseeing advanced practitioner to be in the same physical location, which was a completely arbitrary requirement in my mind, because we, for example, rotate clinician across clinics to essentially a more specific oversight layer, which works better digitally. But that was honestly stupid. Since the pandemic started, they changed the regulations so that physicians can more virtually oversee advanced practitioners. Advanced practitioners obviously are very critical to kind of fill the primary care access gap in this country.
Alex, I think about this one. I guess I think about myself as having being a pragmatist with a very firm value-based core. And to me, I don't mean that as a pun. I mean, I do believe that we need to be doing things to be able to shift how healthcare business models happen in the United States. I mean, I am a believer that value-based care aligns the interests of health systems and patients. Patients don't want healthcare. They want to not have to have healthcare. And our move to value-based care is the way to be able to align those incentives. I also think that as a pragmatist, that if we wait for that to happen, we are leaving a lot of opportunity on the table. And so thinking about how we can innovate inside of the existing majority of fee-for-service is an important aspect of it also. I think it's necessary for us to be able to do both of those. If we don't, the other piece that I think will happen is that we are seeing increased presence and aggressiveness of new entrant competitors into the healthcare space. And if healthcare delivery systems don't think about innovative business models, if they don't think about a shift from fee-for-service to value-based care, and if they don't think about how to better navigate and differently navigate, even through the fee-for-service landscape, I would say with pretty high confidence, there will be big, aggressive, new entrant competitors who will be happy to do that. They will meet healthcare consumers, patients, where they're at. They will bring digital tools that make the care delivery process more efficient and accessible and affordable. They will make cost transparency easier. There are companies, I mean, I think if health systems don't see that and embrace it and see it as an absolute imperative for their continued relevance and impact, Walmart will be happy to take their operational expertise and bring it into healthcare. Their stated goal is to be the largest primary care provider in the world. Amazon Care, I don't think that anybody would be deluded to think that they have small ambitions or that they're there only to serve the employees of Amazon. And these are folks who know how to operate, who know how to provide a consumer-centric experience. And I think that there's a healthy sense of question among existing health systems, patients, and providers about whether the incentives of those groups are aligned with where we would want healthcare to go. So I think it truly is, it is our choice about how we meet those new challenges. Karen, what do you think?
Yeah, I think both Ray and Aaron raise really good points. I think what I have to say about what we've seen in the pandemic is we have known for 20 years that the approach to primary care should be population-based. We have known for 20 years that the fee-for-service system was broken horribly in our what we would call a normal time period, never mind a pandemic. So at Geisinger, we're proponents of moving to value-based care. We have our own health plan, and we do reimburse the enterprise, the clinical enterprise, in a value-based way, but we still have a large number of, it's a mixed system, right? It's not a closed system, so we still have a number of other payers. And I think particularly, and really this is evident through all of providers in the health industry, is that for the pandemic, we did everything we were supposed to do. We protected our patients by not bringing them in to clinic. We protected our patients by not bringing them into the hospital. We physically distanced. So it wasn't about shutting down, it was about physically distancing. And that was the important thing to do. And really primary care groups across the country and all healthcare providers were decimated in terms of financially. So there's something dramatically wrong when you have a system that does the right thing for patient safety and health and is penalized for it. There's something wrong there. And I think we've known this. This is not new news to us. And I think the question is, as an industry, to Ray's point, are we going to move to value-based and insist as providers, really do advocacy as providers to say we believe in value-based and we should be paid on a population-based per capita payment because we believe it's the right thing to do. And I would finally just add that, I worked for the state and the federal government, worked on multi-payer global payment models for the state of Maryland and also for rural Pennsylvania. And interestingly enough, when we were doing the calculation for the global payment, we included an extraordinary event like a pandemic. So we said, here's the fixed global payment. What do we do if there's this shift, this market shift of either increase or decreased utilization? And how do we protect the provider in a way that makes sense? And I don't think we ever talk about that with fee-for-service. So in terms of doing multi-payer global budgets, that was forefront. Let's talk about all the scenarios. And I think they were probably the only two instances in my career that I engaged in a conversation that applied to a pandemic, which we hope we'd never see, and we did.
Yeah. I'm going to transition over to some of the Q&A questions now. How important are care teams in helping patients navigate these systems as we talk about an omni-channel or a distributed system that occurs in the office, that occurs at home, that uses digital tools? How do care teams and care navigation integrate with those tools, and how relevant are they to this new model of care?
I'll give a quick answer on that one. And to me, I think they're critical. They're critical to care as a whole. I mean, if we put all of the burden on individual providers rather than on care teams, I think that not only do we not have people practicing at top of license, we don't have enough resources to be able to go around. So care teams as a whole are critical to high quality, accessible, affordable, scalable, sustainable care. The other thing I would say is that we have to broaden that definition. We have to be thinking about not only our traditional view of care teams, but what I would consider digital care team members. What are the tools that we can bring in that can truly augment that team in new and important ways? The care team is more than just the bodies that we throw at the problem. It is, rather than attacking it with picks and shovels, how can we bring a combine to the problem? How do we do that more effectively? And I think the analogy or the analogous piece in healthcare is those digital care team members, introducing them and making them an integral part of the process.
I think the other thing, Ray, I would add is the importance of looking at a population to say, what do they need and what care team do they need? So
Agreed.
Every patient in a practice doesn't need the same care team.
Yes, Karen.
The 23-year-old that's coming in, to get a form filled out does not need a lot of attention. But the 64-year-old with hypertension, diabetes, and congestive heart failure needs a lot of attention, and they need a team. So I think, again, one of the things we have not been in the past as deliberate maybe as we could have been with designing care teams around patient needs. And we've kind of said, this is the care team that we're going to use for all of our patients. And I think that led to too heavy a touch on some and not heavy enough on others.
I would totally agree with you on that front. I think healthcare has got a pretty long and storied history of telling patients what they should do rather than adapting and helping patients get what they want and need. Sounds like we should sit down over a drink sometime.
Aaron, do you want to pitch in here?
I think the only thing I would add is like resource allocation obviously is very critical for care. So like, for example, one of the problem mistakes, like technology design mistakes, I see a lot of the traditional HR do is they allow the patients directly communicate with the providers, right? This sounds like it should be a good thing, but the reality is more than 90% of what the patients need is usually not something that requires the provider's attention, but the 10% like should be really prioritized for the provider's time. So like one of the kind of the way we improve this is we made it so that all the messaging communication threads are team-based, right? We're essentially asking the questions always to a team of people, and very only when we need the provider's time, we actually kind of notify the provider so that the providers can actually respond to all the critical messages in a timely manner, right? I think this is not just like about opening the floodgates and letting patients do whatever they want, talk to providers whenever they want. That is not going to be efficient because, again, provider times is expensive. But I think really what you're trying to do is like you need to do is just find the right person to deal with every form of problem, and that requires digitization.
So the next question is whether any of you use or have used patient-generated health data in your systems for patients with chronic diseases. I want to make sure that we expand that beyond just data coming in from monitoring devices and also include things like PROs, patient-reported outcomes, elements of shared decision-making, and literally patient-generated data.
Yeah.
It's what we do. Yeah. Sorry, Aaron, go ahead, please.
No, it's the same. Like we have been doing this for 4 years now. So we collect detailed history of present illness before the visit, patient-reported outcomes after the visit, medical history, and device status. That's really that is one of the biggest ways you can make the care more efficient in general. Because reality is the most time-consuming part of doctors' work is not even asking the questions. It is entering patients' HBI, history of present illness, into the chart. That's actually the most time-consuming piece, because there's a lot of sometimes less relevant information that the patient verbally brings up. So bringing structure to that is actually a huge driver of efficiency.
And I think I completely agree with Aaron. I had someone tell me once that the best EHR system is the one that never needs to be touched. I think, if you think about, 100 clicks to complete a visit, providers spending, 70% of their time in an EHR system. What we've focused on is how do we support health systems in gathering all of the right information from all of the relevant sources, and then synthesizing that into the most actionable, usable, high value format for the clinicians. How do we get that information in front of the clinicians in a really actionable way? How do we make it so that it's 5 clicks instead of 100 clicks? How do we streamline the downstream process? How do we get that information back into the EHR system, all while empowering the clinician to be exercising their clinical judgment through that care delivery process? And what we've seen is that by taking that kind of a care automation approach, it's not just about delivering care remotely, it's about bringing tools that streamline those processes and give the clinicians what they need. We can bring an order of magnitude improvement in cost and efficiency and experience of care to everybody who's involved in it. So I think this is that concept of empowering patients and bringing tools that help them play a more active role in that process is foundational to what we do at BrightMD.
I think the other part is here's an opportunity that we can really mine the patient-reported outcomes with artificial intelligence and machine learning, and really give us some really glean some new information on, what would patients report 4 days before they have an exacerbation of congestive heart failure? What would they report before they go into DKA a week before? Are there, we have identified the hallmarks of disease based on when they exacerbate, but we never look at the period of time immediately prior to see where are the interventions that we could make at an earlier date. So in other words, if I was monitoring all of our CHF patients, and we said, please tell us, report to us how you feel every day, and they noticed 7 days before they hit the ER that they had increasing episodes of shortness of breath, I could then program that remote monitoring to say 7 days before, to really look at what are the reported outcomes on patient-reported outcomes on shortness of breath prior, so I could intervene earlier so that ED admission never took place. So I think really patient-reported outcomes, we have undervalued patient-reported outcomes. I think that's a tool in primary care that we could leverage significantly going forward.
The issue of the physician and the provider experience has really been kind of central to what we've talked about today. I'm going to ask a question. Paul, I hope you will forgive me. I'm going to rephrase it a little bit. What's the best way we can introduce providers to these tools, whether it's telemedicine, whether it's other virtual tools, whether it's this expanded model of care? How do we train them, educate them on the benefits, and drive usage and encourage them to really continue with the progress that we've seen over the past 6 months? Is this something that has to happen early on in training? Is this something that can be done, on the spot live? What's the best way to do that and make sure that we can continue to see the benefits of the technology?
I had a design and usability expert, a friend of mine, Liz Bacon. She told me once that nothing is intuitive. The best that we can do is be highly learnable. And you know, the idea that clinicians have to spend a week getting trained on their EHR system is sad. It speaks to how complicated and difficult we've made those tools, how unlearnable they are. I was at a conference back when those were things, like an in-person conference, and it was about telehealth, and more than half of the content was about how to train clinicians on how to deliver care via video-based telehealth, you know, and how do you put together the curriculum, and what do you need to be teaching, and what's, you know, I mean, there were reams of information and panels and presentations about that. To me, it comes back to this question of, are we approaching it with the right mindset? I mean, as a solutions company, I think of it as my job and our job as a company to build tools that don't take that. I mean, we've seen our health system customers ramp up, to almost 200% in their utilization and in the clinicians that were using the platform in under an hour. If we're building tools that require it to be incorporated in so that people have to go through an extended process of learning how to use them, we arguably haven't built very good tools. We need things that work better than that.
Karen or Aaron?
I'll add a quick comment. Like, in this country, I mean, this is honestly all around the world, cab drivers have 10 times better technology than doctors have. So, which is obviously absurd, like thinking of how expensive it is to train each doctor. So I think that this is, I see it mostly a design problem. The tools are unnecessarily complicated, not really designed with kind of with the user-centric approaches. So it is a solvable problem. Well, we need, I would say, like the bigger problem, or the bigger problem is the people who are best at product design technology are afraid of getting into the healthcare world because how complex it looks from the outside. So like that's a really core problem. So the intersection of people who are great product designers, developers, and people who are not, who are willing to enter the kind of take on the complexity of healthcare is relatively small.
You know, Alex, I'd add one piece to this. I think Aaron's right. There's an interesting reputation that healthcare.
Aaron.
What's that?
I'll give you a minute, and then we're going to kick it to Karen for the last.
Yeah, apologies. I'll make it super fast. Healthcare and clinicians have a reputation for not being willing to embrace new technology, and I think that that's a fallacy. In fact, you know, we actually the first professional group that surpassed 90% penetrance on smartphone utilizations, physicians. Physicians aren't averse to technology. They're averse to technology that makes their job hard.
Karen, you want to wrap it up?
Yeah, I will, Alex. I think to sum it up is we have to demonstrate value. So the reason why we adhere to new technology, or that we adopt new technology in a comprehensive way, is because we recognize value. And I think if we demonstrate value to our clinicians, they are going to adopt that digital technology.
Well, thank you all so much for your time. Thank you to everybody listening. Hopefully this was an interesting and helpful conversation. I know I found it fascinating. For those of you who have questions that weren't answered yet, I really hope we'll be able to get to them. And I think at this point, we are going to hand it back to the HLTH GoLIVE team. I hope everybody has a great day. And to Ray and Karen and Aaron, thank you again so much.
Thanks, everyone. A pleasure.
Yeah. Bye.
Thank you, Alex, and to all of our panelists. If you'd like to continue the conversation, please join us on Twitter. And now, please welcome our expert mixologist, Sarah Tracy.
All right, hello. Hi, everyone. So thank you so much for having me to bring a little bit of fun cocktail inspiration to your Thursday. My name is Sarah Tracy, and I am a professional sommelier and a beverage expert based in Brooklyn. So I'm coming to you from my kitchen right now, and I'm going to show you how to make 2 cocktails today. They're both very simple, but pretty impressive at the same time. And I was inspired by the beginning of October, which today finally we're there, to go with a spooky season theme. So I always say, who needs candy when you can have Halloween cocktails? For me, I would prefer to have a cocktail any day. So the first one I'm going to show you is called Death Becomes Her. I named it that after one of my favorite spooky season movies. And this is a rum-based cocktail. So I'm going to, first of all, grab a cocktail shaker. I have mine right in front of me here. And the first thing I'm going to do is add my rum. Hold on one second. I feel like there's a little audio. All right, I think we fixed that issue. So I'm going to start with a spiced rum, and this is my favorite. It's called Chairman's Reserve. They are a craft artisanal spiced rum out of St. Lucia, and you can definitely use your Captain Morgan, your Sailor Jerry, but I prefer to use this beautiful Chairman's Reserve. It has lots of cardamom, clove, lots of great autumnal flavors. So you're going to start with 2 ounces of your rum. So that's 1 and 2. Then I'm going to add 2.5 ounces of pomegranate juice. I just love how like bloody and sinister the color is of pomegranate. If you can't find pomegranate, you could absolutely use cranberry instead. So I will do 2.5 ounces of the pomegranate going in my mixer. Then I'm going to add 1/2 ounce of lemon juice, which this just perks up the flavors a little bit. It gives it a little bit of a lift and brightness. So just 1/2 ounce there. And then my favorite part of this cocktail, besides the rum, of course, I'm going to use pure maple syrup as my sweetening agent here. This is the grade A dark variety, and this is such a great secret to fall cocktails. Anything that you might use a sugar syrup or a simple syrup in, if you're going to do it in fall, you can use maple syrup, and it just gives a lot of depth of flavor and brings me right up to like autumn leaf season in New England, which is amazing. So 1/2 ounce of your maple. And finally, I'm just going to add a few dashes of aromatic bitters. Cocktail bitters are essentially spices and herbs and botanicals that have been extracted and dissolved into alcohol. These are meant to be just a little like extra seasoning and extra spice for a cocktail. So you really only have to use a couple dashes of this. I like the ones from the Bitter Truth. This is the brand I'm using, but Angostura bitters are very common, easy to find everywhere. You could definitely use those. So, you know, just a few dashes of my bitters. And then finally, I'm just going to add ice to my shaker. And then pop on the lid and give it a really nice shake. This is gonna help, you know, not only combine all the flavors, but the ice gives what we like to call dilution. It just balances out, and you'll have a slight tad bit of the ice melting into the cocktail, which is going to really make it seamless and smooth. So I'm just gonna go for it here. All right. Now I'm going to strain it into a rocks glass. I already have some ice in here. Give it a nice strain. And then I'm going to top it off with even more autumnal flavor with ginger beer. This is the Q brand Spectacular Ginger Beer. I love it. It's a little less sweet because we already have that beautiful maple syrup in there. I never feel the need to add a really sweet ginger beer. This one's very spicy, very fizzy, and not so sweet. So I love it in this cocktail. And I'm just going to top off with that. And then this is going to be the party trick, my garnish, which is really fun, is that I'm going to take a sprig of thyme and garnish like that. But if you want to make it extra spooky, I'm going to light the thyme on fire. And again, this is something really simple that really anyone can pull off at home, but it's just going to give a really spooky waft of smoke popping up through the air, and it'll give a little bit of aromatic complexity as well. I'll hold it up to my camera, but I don't know if you all can see on camera these amazing wafts of spooky smoke. If that's showing well, but it is looking very eerie, very spooky. And it just tastes like fall in a glass. It's spicy, it's gingery. You have the pomegranate, a little bit of that fresh lemon, perk everything up. It's really a balanced cocktail, just delicious. And again, that is the one I've called Death Becomes Her. So that is cocktail number one. I hope you make it for your friends and family. If you are going to be celebrating Halloween this year, or even a scary movie night, this would be a fun, welcome cocktail to make for everybody. And then I have a second cocktail to show you called the Black Widow. And this is a 0 proof cocktail. So I don't like the word mocktail. I feel like it sounds a little plagiarizing. So most mixologists, bartenders, us beverage industry folk, we like to call them 0 proof cocktails because if you're not imbibing alcohol, you should still be able to have a finely crafted, very sophisticated, delicious drink, and it may not have alcohol in it, but just call it a 0 proof cocktail, I think is awesome. And this one, I am going to actually build inside a mason jar because this is a great to-go cocktail. If I build it in the jar, I can just twist the lid on and throw it in my bag. If I'm going to maybe be joining some trick-or-treaters this Halloween or meeting friends in the park, I think it's a fun idea to just build it right in a jar. And so with this, I'm going to start with, because it's called the Black Widow, we need a good black color here. So I have blackberries, and I'm gonna add like a good handful, like 8 of them or so, into the bottom of a mason jar. Yeah, just till they're like covering the bottom of your jar. And then one thing I love to incorporate into cocktails, like you saw with the smoked thyme in the Death Becomes Her, is a little bit of an herbal component because that adds a lot of sophistication with not a lot of effort, which is my personal trademark. So I have a sprig of rosemary, and I'm just going to pluck off the leaves and add them to the blackberry here. You don't really need this thick stem, doesn't add anything in terms of flavor. But the leaves, oh, just smelling them now, they're so incredibly aromatic. They're gonna give so much sophistication to this cocktail. So excited. Okay, then you're going to add a little bit of lemon juice, about the juice of half of a lemon, which again, if you're using a jigger, is again about 1/2 ounce. And then I'm going to use some honey. Like the other cocktail, we used maple syrup. Honey is also a great way to bring a lot of complexity, have a sweetness there, but have it be really interesting. This is a rosemary honey from the Savannah Bee Company. And because I used rosemary leaves in the cocktail, I thought it would be really fun to have double down on rosemary and use the rosemary honey. So this one you can eyeball, depending on how sweet you like your drinks. Like 1 tablespoon, 2 tablespoons would be fine. This honey is also incredible, drizzled on a cheese board. But yeah, that's good for me. Just a nice little healthy glug of rosemary honey. And then all we have to do is get a muddler, or you can get creative if you don't have a muddler at home. I've used everything. I've used like the end of a rolling pin, a thick spoon, but really what we want to do is we want to get in there and crush those berries so they are releasing all of their juices, and also combine the essential oils and those rosemary leaves into the drink. Oh, amazing. This smells incredible. The rosemary, the honey, the blueberry or the blackberry juice, and that little lemon just smells incredible. And then all you have to do is add ice. I'm gonna put that right in my jar. And then a little club soda to top it off. You could use LaCroix, you could use your favorite sparkling water. I'm just using basic old Canada Dry club soda, but I love the way those blackberries kind of very sinisterly like float up through the glass. And then I would take a festive straw to combine everything, kind of get it mixed around a little bit. And finally, garnish with a rosemary sprig, just adding more rosemary deliciousness to this cocktail. And again, this is something you could certainly add vodka, gin, or tequila to if you wanted to, but I love it just as is. A fabulous zero proof cocktail for spooky season. That's beautiful, balanced, really fresh. And again, you could take it to go and just remove your straw, do this lid, throw it in your bag. You are ready to enjoy on the go. So those are our two cocktails, the Death Becomes Her, and then also the Zero Proof Black Widow. Thank you all so much for inviting me to join your event today. I hope you have a fabulous October and you have fun making some of these cocktails at home. Cheers.
Thanks, Sarah, and thanks everyone for joining us today. Have a great rest of your week.